Time to talk about the proposed rule for 2027. We'll talk about these topics. So let's start with some scoring rules. The key thresholds, the performance threshold and the data completeness threshold, no change for 2027. They're holding previously, it was previously set at 75 each through the 2028 performance year. Of course, that could still change before the 2020, for the 2028 performance year, and certainly after 2028, it could still continue the same. We shall see. Couple proposals for the exceptional and uncontrollable circumstances. They've been using PCOS to determine the location for practices to include in automatic EUCs, and they're proposing to remove that just to be more flexible, finding the most accurate and up-to-date localization for practices. I didn't realize there was a special EUC application for third-party failures, but Medicare does have a mechanism if the third-party vendor fails to submit data for a client. You can request any use. A practice or a provider can request any EUC for that. The current deadline is November 1st after the submission deadline, and they're proposing to extend it to December 31st after the submission deadline. For the quality category, just the usual changes in quality measures, a few new ones, dropping a few, changing a bunch. They're adopting 4 QCDR measures or proposing to adopt 4 QCDR measures as MIPS CQMs. That's the first time I've seen that happen. So it's an interesting dynamic. They're replacing 7 functional improvement measures with 5 functional outcome measures for orthopedic patients. That has some pertinence for the MVPs, which we'll get to in a few minutes. And we'll get to this high priority measure designation, the last bullet there, in another slide. Oh, in fact, this is it. Proposed to sunset the outcome and high priority measures, replacing it with a new concept called MIPS core measure designation. They're proposing that designation for 78 quality measures. Core measure reporting to apply to both traditional MIPS and MVPs. So any traditional MIPS or MVP reporter would need to include 1 core measure, one of the 6 for traditional MIPS, one of 4 for MVPs. They'll designate in each MVP what's available as core measures. Small practices to be exempt from the core measure requirement. If the practice doesn't have one that applies to them, they're asked to attest that there's no applicable core measures and replace it with something else to get up to their 4 for an MVP or 6 for traditional MIPS. Topped-out measure, a defined topped-out measure with an expanded point availability. You may remember that topped-out measures typically have a limit of 7 points at maximum. Last year, they introduced this concept for measures that are essential or viewed to be essential to certain specialties because they have very few to choose from. They gave this expanded point availability to use the whole point spread from 1 to 10. They've defined 17 measures to take advantage of that, and also suggest that core measures that are topped out will be included in that list if this is accepted, this is finalized. Oh, and the other thing, they'll maintain the list on the QPP website rather than in the Federal Register, and therefore not plan to include it. I think that means they won't plan to include it in the rulemaking cycle to bring it into the proposed rule and final rule. For the cost performance category, nothing really significant happening there. For practice improvement, the usual adjustments, take a few away, add a few, alter a few. No, no big changes there. I didn't go, well, new emphasis on these topics, wellness, diagnostic performance. So I think I have the list. Here's the list of 6 they're proposing. Use of data, understand and improve diagnostic performance. Interesting. Number 5, clinician use of AI to improve patient care. Interesting year for promoting interoperability. The first bullet here align with the proposed ONC decertification policy. They're actually trying to back off on some of the certification activity. And I'll get into that in, I think, the next slide. Proposing to remove a couple of the attestations, including the security risk analysis, which has been there forever. The direct attestation is agreeing to cooperate with ONC if they ask to review your use of certified EHR, and the ACB is to agree to cooperate with the authorized certification body if they ask to review your use of CEHRT. Proposing a new electronic prior authorization measure, which will be a bonus for 2027 and required in 28, and electronic prior authorization for prescriptions, proposed to be required beginning in 2028. Here's the decertification proposals, proposing to remove the requirements and the certification standards for family health history, patient health information, automated numerator recording, automated measure calculation, and clinical quality measure. The number 4, the C4 certification for clinical quality measures. I don't think this represents a view that it is less important, just a view that it's that they don't see value to continue to measure its capabilities and certification, that it's good enough to typically to pass. For MIPS value pathways, here's a big one. They finally set a date or propose a date to sunset traditional MIPS after the 2028 performance period, with MVPs required for anyone who's not in an APM for to start in 2029, with virtual groups in that year being able to submit MVPs. The biggest change, they're proposing 3 new MVPs: diabetic disease, hypertension, and hospitalist. Meaning there'll be, if this passes, there'll be 30 MVPs to choose from for 2027. They're renaming rehabilitative support, which obviously is not real important, but alert. For alternative payment models, this is interesting, creating a little complexity for QPs and partial QPs. Looks like this is not going to be subject to any comments, because they're required to do this by the Consolidated Appropriations Act of 2026. But we'll see. The chart on the right shows the thresholds to be declared a QP or a partial QP by year. You'll see the 2024 year had the 50, 35, 40, and 25 thresholds. It went in 2012 to 70, in 25 to 75, 50, 50, and 35. In 2026, they're proposing to be retroactive for this year, to put those thresholds back to what they were in 2024, and then back again to what they were in 2025 for the 2027 year. So I think you can count on that happening, since it's required by legislation. I don't expect them to be able to respond to complaints that it's complex. Also, another really interesting one in that in the conversion factors, the physician fee schedule presents relative value units for every billing code. One for practice expense, one for complexity, and one for malpractice expense. Added all, give them geographic modifiers, add them all together, and then multiply them by a conversion factor to understand what each code pays um, as an allowable charge. So proposing for 2020. And part of the value of being a qualified participant, a QP, is a starting, I think it was last year, a higher conversion factor. So they're first time I'm aware of them reducing a conversion factor in a year. So they're proposing to decrease the conversion factor for non-QPs uh, by 1.68% and decrease it for QPs a little less by 1.19%. I imagine this will generate a lot of commentary. For the MSSP, first, just presenting some of the newer numbers. 511 ACOs for the 2026 year, with more than 700,000 NPIs and 12.6 million beneficiaries. I think that's a little less than half of the NPIs and a little bit less than a third of Medicare beneficiaries. For the performance year 2024, which is the last one that's been completely evaluated and the numbers are public, 75% of ACOs earn shared savings. Um, Medicare paid out 4.1 billion in shared savings payments and kept 2.5 to reduce expense to the Medicare trust funds. So it is certainly looking like the MSSP they're considering to be successful, and I think that bodes well for its continuation. Um, and there's a lot of new MSSP proposals. First, the track and potential shared savings from those tracks. They're proposing to increase the maximum maximum possible shared savings in the basic track, combined with a reduction in the enhanced track. Maintain the enhanced track maximum at 75%, but reducing the regional adjustment. There are every ACO when it gets started has 3 benchmark years, so 3 years before they get started. Um, Medicare measures the average weight, the average expense per participant, and then adjusts that rate every year of performance from that benchmark, and it's adjusted for regional variation. So you get a little bit more savings, even if your costs are high. You'll save more if you're below the regional average. They also look at a national average, and likewise, even if you're still high, you'll save more if you're better than the national average. And then there's an adjustment for your own previous or sharing weight. So it helps to prevent a ratchet effect that happens when someone very good gets into the program, that they can still save more. This change is related to an observation that in the transition from level E in the basic track to the enhanced track, which is the next level. Basic level E is the only level in the basic 5 tracks that has a more than nominal potential loss rate. Um, so a practice or an ACO can stay in that level E almost indefinitely, I believe. What they're finding is people are changing from E to enhanced track and getting an increased shared savings over a couple of years without any actual performance improvement because of the way those balances were working. So they propose to block some of the regional adjustment to that enhanced track and increase the shared savings in the basic track to combat that. They expect to see more people staying in the basic track, and they expect to not have to pay out as much shared savings because of not getting them into the enhanced track as quickly. So it's an interesting change. Relating to this, if it passes, they'll give an opportunity for applicants to change their basic to or enhanced selection before after the final rule is out. Growth adjustments, they're establishing a numerical adjustment for ACOs that grow, particularly by adding professionals that are new to value-based care and continuing that just to encourage ACOs to grow. ACPT guardrails, another protection. Oh, the the benchmark cost of patient care, when they set those benchmarks, they also establish an expected growth rate. So if you continue as you have in the past, your cost will grow or shrink by a predicted amount in the coming years. And they build that into the payment so that you can experience some growth of your charges and still save, still maintain your sharing rate and your shared savings. They're capping that or proposing to cap that at 1% below or 1.5% above the national growth rate, and apply it retroactively back to 2025 in some cases, um, calculating that reconciliation at the end of in November of this year if that's finalized. So the way that's applied, typically your benchmark is updated annually by 2/3 of the weight based on the national and regional expenditure growth, 1/3 on your own predicted rate. So it's an adjusted prediction. Here's another big one. Um, Assignment and beneficiary engagement, proposing to remove the prepaid shared savings option, proposing to allow ACOs to reduce or eliminate the Part B cost sharing. So that's your copay and deductible, which is very interesting to create create incentives for practices for beneficiaries to use the ACO instead of going elsewhere. They're putting exceptions to durable medical equipment and to prescription drugs, but for those things that track to the practices and to the professional services, um, they'll permit that, or they propose to permit reducing or eliminating that cost share. They're also creating some dynamics, the last three bullets on this page, to increase the likelihood that a beneficiary is um, attributed to an ACO. And those couple of changes right now, when the NPIs are working in an ACO practice and a non-ACO practice, they often see patients generating visits in both of those practices. And then the tax ID number gets credit for the visits and the allowable charges, which and that is how they calculate the plurality of care, which attributes a patient to one practice or the other. they're proposing when an NPI is working both in an ACO tax ID number and a non-ACO tax ID number, that they eliminate the patients who are seeing them in both from the non-ACO tax ID number. So that pushes a higher volume into the ACO tin and makes it more likely that they get attributed. There's also a pre-existing dynamic. If you look at that, an ACO being a conglomerate of many practices, when patients are seen across several practices getting primary care services, that tends to increase the plurality that tracks to the ACO. So there's a few dynamics that make it more likely for an NPI to be attributed to the ACO. They're also proposing a change in eligibility criteria. There's current language that says to be eligible for attribution, you have to be on both Medicare Part A and B for at least a month, to have no months of only Medicare A or only Medicare B, and to have no months of Medicare Advantage. So anyone with only one of the parts, anyone on Medicare Advantage is really out for the year. They're proposing to make it only a month. There's in any month that there's your only Part A or only Part B, or you have Medicare Advantage, the beneficiary is not eligible for attribution. But the next month, when they're on both A and B, then they are eligible for attribution. Together, there's over 200,000 patients, beneficiaries, they expect to be attributed when they look at last year's dynamics. Also, the usual updates in primary care service list for those plurality calculations. Interesting, and of course, the big one, MIPS CQM collection type and the reporting incentive proposed to be continued. Cancel the sunset. I would judge this as highly likely to pass. To be finalized. I don't know anyone who has been lobbying to see it happen and to be limited to ECQMs in the coming years. So I expect to see this finalized. They're also proposing Medicare ECQMs as a collection type, the dynamics to be similar to Medicare CQMs, and also proposing to use flat benchmarks. The justification being, you're aware that for collection methods, Medicare generates benchmarks specific to each method. So for ECQMs and MIPS CQMs, which are in use both in the MSSP as well as in MIPS, you end up with most of those being benchmarked against all providers in the nation that are using those measures. Since Medicare CQMs and Medicare ECQMs are only applicable to ACOs, they end up being benchmarked against each other. And Medicare does observe that ACOs tend to score higher on all these measures, average in that graded on a curve in a group of typically excellent performers. So rather than accept that, they're proposing flat benchmarks, which is based on the performance itself, not on its comparison to everyone else lined up by deciles. Oh, they're expressed some displeasure with tax ID numbers being excluded from ECQM reporting for ACOs, and proposing another data completeness threshold just for those TIN exclusions. So saying it's okay to eliminate one or more TINs as long as you're reporting on at least 95% of beneficiaries. Very interesting. Maintaining the 75% data completeness threshold overall. I will be commenting on this as unnecessarily complex and confusing, because that 95% threshold is duplicative of the 75% data completeness threshold. Still leaves you with a question of how you measure that. They haven't really addressed that in this proposed rule. And that inability to get data from some of your practices is really the only thing that the data completeness threshold is useful for. There's really no other reasons to have less than 100% reporting rate. For the APP Plus measure list, proposing to cancel the substance abuse measure and the adult immunization status measure. So we'd stay stable if this is finalized at this 8 measure list on the right, which includes, of course, caps for MIPS and the 2 administrative claims measures, the readmission and admission rates measures, with the other 5 being the submittable measures. Very interesting relaxation of cert use requirements, or at least proof of your cert use requirements. Proposing to cancel the requirement to make a PI submission and instead require a choice of one of these other methods listed in the lower big bullet here. So you can choose to report at least one AP Plus measure as an ECQM or Medicare ECQM. I would imagine that they'll be looking for 100% reporting rate to prove that everyone's on ECQM. I don't know what they haven't addressed what happens to the practices that still have an exclusion for use of CEHRT, because that the small practice and the non-patient facing exclusions are still there for participants in ACOs. Second choice is to attest that you've used the FHIR-based API to support your quality measurement. And the third is to select any one of these cert use metrics, either submit the ACO electronic prescribing, testing, not submission, attest to electronic prescribing, health information exchange, or provider to patient exchange. So that certainly will be an interesting change if it is finalized. Beneficiary notices, just proposing to be less restrictive or prescriptive on that. Proposing to reorganize advanced investment payments, to remove the ADI, that's the disability index, or not disability, but disadvantage index, and simply pay $45 per user who's on a low income Part D program, is dual eligible, or is in a rural county, and $25 for other assigned beneficiaries, with a cap on that advanced investment payment if there's at 10,000 beneficiaries, nothing beyond that to be paid. And some discussion of risk experience as the ACO expands. Really, one change to the ambulatory specialty model. Actually, a little more in the detail. Nothing that's earth-shattering at the moment, but I think it was worth bringing up that they are projecting the payment adjustment range to be plus or minus 9% in the first 2 payments years, and then planning to increase to plus or minus 12% by the final payment year. Also replacing the Q220 functional status change back pain measure with the Q182 functional outcome assessment measure for back pain. So that takes it away from the photo measure into something else. I think just more choices, different structure to that measure. Also, describing management of NPIs who change their TIN or their specialty during the program years. So they've outlined several of those and how they would manage it. Specialty is particularly important in the cardiology. They did define, look carefully at the other cardiology specialties like electrophysiology and cardiac surgery and the hypertrophic cardiomyopathy specialties and others, and concluded that the cardiac subspecialties are procedure oriented, so reinforce their intention to just use general cardiology as the cohort of specialists for heart failure. And if someone during those years defined their specialty from that general to one of the more specific ones, they'd be cut from the program. So I expect that would probably be the reason people would choose to do that, so they won't be held responsible for this program. And then just the last slide, a set of requests for information, which I think mostly gives users a chance to comment on these RFIs. We expect to see in the next rulemaking cycle some specific issues. So I still have some more of the grisly details to go through, but I think I've hit the highest points. Thank you, everyone. Thanks for the comments, questions, participation.